You hear me? In 1865, William Booth founded the Salvation Army. In 1868, the 14th Amendment to the Constitution was ratified, granting citizenship to all persons born in or naturalized in the U.S., which included former slaves, and guaranteed equal protection of the laws. It was one of the 3 amendments that was passed during the Reconstruction era to abolish slavery and establish civil and legal rights for Black Americans. In 1885, Ulysses S. Grant, the 18th president of the U.S., died of throat cancer. In 1903, Ford Motor Company sold its first automobile, the Model A. And in 1995, 2 astronomers, Alan Hale in New Mexico and Thomas Bopp in Arizona, almost simultaneously found a comet, which became known as the Great Comet Hale-Bopp in 1997. And that's it for history for this date. At this point, I'd like to introduce today's speaker. I'm going to mute the audio for the group, and then Scott, you'll have to unmute your microphone if you would. Give me just a second here. Okay, everybody should be muted, and I'll go forward. Our speaker today is going to be Dr. Scott Douglas from the Montgomery County Health Department. Scott is a Wabash graduate, class of '84, graduated from the Indiana University School of Medicine in 1988, did his family practice residency in '91 at Methodist Hospital, was in the Air Force as a flight surgeon from '91 to '94 with the 7th Wing, the 9th Bomb Squadron, which is a squadron of B-1B bombers. I lived in Wichita, Kansas for 10 years. We had a B-1 squadron there. Every day was an air show.
Yeah.
Because we lived directly under the approach to McConnell Air Force Base. So fond memories of that. He's been in family practice here in Crawfordsville since 1994 to present, and became Montgomery County's Chief Health Officer in 2016 to present. So Scott, welcome to Kiwanis, and let me change over to speaker view here, and I will turn it over to you.
Well, thank you. And Jerry, if you can make me a host, then I'll be able to share, or a co-host. I'll be able to share a few slides on the screen, but can everybody hear me? Okay. First of all, thank you for including me in your meeting, and because this is a time where there's a lot of information out there, and it's hard to sort through the information and know what's valid and what's not valid, and what's actually happening and what's hype. And so maybe I can help with that. When Jerry called and asked, if I would be willing to talk to Kiwanis, I thought I better know a little bit about Kiwanis. So I went on Wikipedia, and you probably all know, I looked up Kiwanis and what that is. You probably already all know this, but it's an Indian word, and roughly translated, it means I can't find, or where is the Rotary Club. And so I've been a member of the Rotary Club since like 96 or 97. I can't remember back when I'm a past president of Rotary. But Crawfordsville, I think, is really very fortunate to have the service clubs that Crawfordsville and Montgomery County has, because of all the good that you all do. And that pancake fundraiser is really something spectacular, and you all do a great job in the community. So I just want to say I appreciate that. So my thought is I will share first a little bit. I want to kind of communicate how contagious COVID-19 is, and then we'll talk about, I'll show you some slides in terms of the incidence of the infection and the prevalence of the infection in the United States and in Indiana, and then kind of talk about where we are right now, and also about where I think we're going to end up, or at least what direction I think we're going right now. So let me get to a couple slides here. So I'm going to change over to a screen share. So first of all, I want to be sure that, can everybody see a slide, or can somebody unmute and let me know, be sure that you can see this?
Yes, we can.
Okay, good. All right, so you might have seen this diagram before. This is an outbreak of COVID in a restaurant that occurred back in January. And the index case was somebody sitting right in the middle at table A on January 24th. And all those individuals with circles, red circles around, are folks that became infected with COVID from that exposure. And so what makes that exposure significant is, first of all, this was this was an event rather than tables changing over randomly. So these were folks that all sat in the same room for about an hour, and so were exposed to each other for a little bit longer period of time. And also, you might recall, back then nobody was wearing masks, so it's folks in close proximity without masks. And the incubation period, as you all heard on COVID, is anywhere from 2 days to 14 days. So all these folks who had outbreaks, the most common length of time it takes before you have symptoms is about 5 days. But all these folks became infected. The other important thing about this slide is the folks that got infected were the folks that were in the airflow of the individual that was sick. So folks on table E and F didn't get sick because they were outside of the airflow. The air conditioner was blowing and circulating, but it was blowing across tables A, B, and C, and those folks are the ones then that got sick with the aerosolized virus. So it's just an idea about how contagious it can be. This is another picture diagram of a call center, and you might have seen this before. So these are folks sitting in close proximity to each other, all talking on a phone, not wearing masks. And in this, you can see, in terms of an outbreak, a large group of folks who are annotated by the blue seats are the ones that got infected. I think one of the important things to realize about this diagram, this is on the 11th floor of a building. So almost everybody, had to take an elevator to get to the floor. And you can see all of the other locations within that floor where there really was not a lot of activity in terms of the virus, or a few sporadic cases on the other side of the floor. So what this is helpful in is realizing that these brief interactions that we have with folks are not likely to transmit the infection. So if you're walking down the aisle at Kroger and you pass somebody on the aisle, even if they're sick, that brief interaction is not likely to transmit the infection. Or if you were to ride in an elevator for 30 to 60 seconds with somebody, that's a lot less likely. It's those sort of prolonged or longer exposures that are much more likely to transmit the infection. This is one of our manufacturers in town that had an outbreak. Each one of these little blue U's is a cell in which 4 or 5 employees would assemble a part and pass it on through the cell. And the red numbers represent folks that got infected in these cells. And you can see the other cells that did not have infected individuals seem to do okay. So working side by side with somebody in close proximity, and I will say that this facility was all, at this time, they had changed their manufacturing so that instead of the employees standing on the inside of the horseshoe or workbenches. They changed some of these workbenches around so that folks stood on the outside of the workbench. So they tried to social distance folks, which really they did abide by the social distancing that's recommended. They also put plexiglass up between workstations when folks were working close together. They were screening everybody, checking everybody's temperature. And nevertheless, and we know why now, that lots of the incidence of asymptomatic infections can be as high as 44%. So folks infected and infectious, were able to get in the door and not feel sick and be past the screening and work in an environment that was at least attempting to social distance. They provided masks, but it wasn't required at that point. And still we had these outbreaks in people working near each other. This facility then subsequently made mask wearing mandatory, and the number of cases has dropped off dramatically in that environment. You might have seen this. This is a choir practice in Washington, and one person was sick and infected 53 people in one choir practice. And the key factor here is they were all indoors, all within a confined space, not wearing masks at that point, and singing. So loud talking and singing spews more of the virus into the environment. So in this outbreak, 87% of the choir members got sick with COVID. 3 people became ill, that were ill enough to be hospitalized, and of those 2 people died. This is a church outbreak. This was a 2-day event that involved, small groups, also shared meals, and 2 people that were symptomatic attended the event, and they infected 35 of 92 people at the event, which resulted in 3 fatalities. And then of those folks, there were 26 additional cases that are attributed that got spread into the community from that event, of folks that didn't attend the event but got infected by somebody who did. And there was an additional death in this outbreak. So this is a map that's comes off of a Harvard site. This is updated daily. This is a map of incidence. Incidence and prevalence are 2 ways that we look at how active an infection is. The incidence is the number of new cases per 100,000 population per day. And so to kind of change or to help you understand in terms of numbers, Florida, for example, you can see the incidence is 52 cases per 100,000 in Florida. In Miami-Dade County in Florida, which is densely populated, their incidence is 104 cases per 100,000. So that's 104 new cases per 100,000 people per day. So to put it in perspective to where we are in Indiana, we are currently sitting at 11 cases per 100,000 per day, but that number has started to trend up. Last week we were at 9.5. On Monday we were at 10.5, and as of yesterday evening we were up to 11.1 cases per 100,000 in the state of Indiana. So it's a trend that's kind of it's starting to worry us. This is from that same site. So this is just drilled down to Indiana. And so you can see really the rural counties in Indiana in the yellow have a lower incidence per 100,000 compared to more of our urban centers like Marion County or northern Indiana or Evansville area or around Cincinnati, where there's the incidence is higher in those areas. And then there's a couple counties that are in green, which their incidence is very low in those rural settings. So that's incidence. Prevalence is a little bit different. Prevalence is the number of people that are actually infected at a given time. So with incidence, you might say that we had an incidence of 11 cases, new cases per day, but the prevalence is how many people are sick at this moment. And that goes back to, there might be people that got sick 7 days ago or 8 or 9 days ago, and that's included in the prevalence. And then there's folks that were sick in the past and they're well now and they're resolved. But the prevalence tells us how many people at once are infected. And that's a hard number to come by. Indiana launched a study to really look at the prevalence, and we're really, all of the Midwestern states are looking to Indiana for this study. This was done by IU Fairbanks School of Public Health in cooperation with the Indiana Department of Health. They're doing a 4-phase study. The first phase occurred in May. They did a second phase in June. They're going to do another phase in October, and then another phase in the early spring, I think in April. And to come at the prevalence, you really have to screen a population randomly who aren't being tested just because they have symptoms. So you're trying to catch how many people out there have the infection who may not know it, or maybe the symptoms are mild enough that they don't need to be tested, or they don't know that they're sick enough that they have the virus. And so for Indiana, the first phase of that in May, the prevalence was 1.7% of Hoosiers actually had the infection at the 1st of May. So if we were going to translate that into the same kind of way we look at incidence, where we're talking about incidence in Indiana being 11 right now, if you were to translate that, the prevalence into a same kind of number, that would be 1,700 cases per 100,000. So prevalence is always higher than incidence typically. When they repeated the study June 1st, fortunately, that prevalence rate dropped down to 0.6%. So 600 cases per 100,000 were sick at any given point. And what's really, I think, fascinating, that was at the beginning of June. Purdue screened their first set of freshmen coming onto campus. 504 freshmen got screened, and Purdue landed exactly at 0.6% prevalence. And that was just at the end of last week. So our prevalence of young adults who are freshmen at Purdue matches the general population of Hoosiers in terms of that prevalence. So, all right. So this gets updated daily this is from the Indiana State Department of Health. It gets updated every day at noon. So this was yesterday's numbers in terms of new cases. We are right now at 58,000 total positive cases in Indiana out of 600,000 folks tested. So 9% of folks tested have been positive, but that's an accumulative rate. We'll talk about more of that later, because if we look at the rate of positive tests, that becomes an important metric that we look at. So here's the state of Indiana with the number of cases in each county, and in the right upper corner is the positive cases by day in the state of Indiana, and you can see that somewhere in mid-June, the number of cases started going up fairly significantly in terms of the number of positive cases per day. Some of that related to just the fact that we got better at testing more people, but I'm going to show you, and this is what's alarmed Governor Holcomb and the Indiana State Department of Health and is alarming to me. I'll show you what our positive rates are doing shortly here. This is the Regenstrief Institute. This is part of Indiana University, and they're helping in terms of tracking trends. And this was our trends on Monday. What they follow is a 7-day rolling average of positive tests, emergency visits, hospital admissions, ICU admissions, and deaths. And on Monday, we were trending up in positive tests, ER visits, ICU admissions. The hospital admits were kind of inconclusive or had sort of plateaued a little bit. Deaths appeared still on Monday to be going down, but I will add, deaths are a lagging indicator. Our positive tests are more real time. They get reported to the state as soon as a local health department gets a positive test result. And by the way, all labs are required to report their tests to the health departments. So those get entered pretty much in real time, usually 48 to 72 hours after the patient was tested. We have a result back and it gets entered into the system right away. So the positive test is more timely. When we're talking about deaths, from the time of first symptoms, if somebody is going to get sick enough that they might pass from the infection, the average length of time it takes for someone to get sick enough to be in the hospital is about 8 days. And the average length of time for someone who ends up getting sick enough in the hospital to be admitted to an ICU is about 11 days. And then once they're in the ICU, they tend, if they're having trouble, they often get intubated or put on a ventilator, and they may be on a ventilator for a week or so. So, and then if they succumb to the infection, it's oftentimes a few weeks after the first onset of their symptoms in most cases. So deaths will lag the general trends by 3 or 4 weeks. And also when somebody passes, birth certificate or death certificates have to be completed, and that goes, the attending doctor gets involved. If there's autopsy, that delays things. The coroner gets involved, and so it's a paperwork thing, and after somebody's passed, nobody views it as an emergency. So that kind of paperwork is delayed, and so deaths, as I mentioned, it's a lagging indicator. So that one's not helpful when we're trying to determine what's happening right now. This was as of yesterday, where our emergency room visits, hospital admits, and ICU visits in terms of trending was inconclusive. In the 7-day rolling average, our positive tests are still going up. This is also from Regenstrief. The important things here is, and folks always want to know, well, of folks that catch the virus, what percentage actually get sick enough that they have to be in the hospital? And if you look at the left upper statistics under hospitalization, out of 8,000 patients have been hospitalized over the course of the COVID outbreak, which has been 14% of positive COVID people got hospitalized. Now, that number is skewed because in the early outbreak in March and April, we weren't testing people except for those sick enough to be in the hospital. So that makes that number go higher. it's really closer to 10% or maybe even a little bit less of folks that get the infection get sick enough that they might have to be hospitalized. I think the other important piece in this information is the fatality rate. If you are sick enough to warrant admission to a hospital, the fatality rate is 18%, which is really very high. If we don't have fatality rates of 18% for most of our hospital admissions, so this is if you're sick enough that the lungs have started having this very strong inflammatory reaction, the fatality rate is going to be 18% in Indiana. The graph here shows hospital admissions. The important, the dark squiggly line, that's just discharges, and the tiny blue squiggly line, that's discharges from the ICU. Don't look at those. Look at just the gray bars. That is the daily number of hospital admissions, which has been going down, but at the end of June has started to trend up a little bit, and that's got public health officials nervous. The hospitalization rate is one of our better indicators of what's happening in the community, and that's created worry. This graph, I think, is the one that is the most helpful for us. The red line are the positive cases. The yellow line is the number of tests being done. So starting back in March, doing very few tests, and over time, our testing ramped up dramatically in the state of Indiana. And as we have been ramping up in testing, we are testing a lot more people that we hope or expect will be negative. We're testing people preoperatively before they go into the hospital to have surgeries. And these are people that we expect to be negative. There are more people getting tested as employers start requiring, in certain settings, folks to be tested before coming to work. Some of the colleges are now requiring students to be tested. So these are all a group of people that we would expect or we would hope would be negative. That blue line is the percentage of positive COVID tests of the people that we're testing. So what's alarming is that as our testing is going up, our increased number of cases is not just because we are testing more. We are getting a greater percentage of the tests are positive, as indicated by this blue line, at 17% currently. So that is another indicator that made Governor Holcomb pretty nervous about what's happening in Indiana. And if you think about what we've done in Indiana to try to decrease the spread of the infection, probably the single most important thing that we did was took kids out of school in March. Kids are a big vector. And so, the hope was during the summer that the incidence of the infection would drop down dramatically and the amount of cases would drop down dramatically, especially with kids out of school. What's worrisome is even with encouraging social distancing and encouraging folks to wear a mask, and still the kids not in school, the numbers are starting to go up. And that makes us concerned about what will happen when we get kids back in school in that kind of congregate setting. But we can't keep the kids out of school forever. The education is critical. The socialization that occurs is critical. But this is creating angst, especially amongst the superintendents of the school corporation, who have to weigh not just the health of the students. They have to worry about their employees, the teachers and staff who, if they do get sick, will likely have worse infections than the children do. The children tend to have, as a whole, their symptoms tend to be less. But we've got the school systems have some important decisions to make, and they are not easy, and nobody really knows the best path to take. And we probably will only know the best path in retrospect when we look back at this in a year. So everybody's doing their best, and you know, in this environment, no matter what the schools do, there are going to be angry people. People angry about going back, or people angry about wearing masks or social distancing, or lots of, everybody from both sides of the fence are going to be potentially upset. So we need to, I think, give those officials some grace as they make some tough decisions here going forward. So I'm going to turn this back over and then open it up for questions. Let me stop the broadcast here. And maybe I can, any questions I can answer.
Scott, in looking at the map from of Indiana, obviously the Indy metro area has been heavily affected. Hamilton, Boone County, it looks like it's coming this direction. Is there any prognosis as to how high that might go and when it might get here?
I think it's really just a function of density of population. So I don't really think it's moving in a wave away from Marion County. I think it's just related to population density, and being a rural community with less density, I think is one of the factors that we are faring better than the urban areas.
Frank has a question.
Hi. Thanks very much for your talk, Dr. Douglas. I had a couple questions. First of all, I wanted to say that the dashboard and the Reagan Street Institute are a little different today. The dashboard has 954 new cases from yesterday and 17 more deaths. The Reagan Street trends, on the other hand, have turned better, so that's a little strange. Although, if you look at the graph you were highlighting, the positive test rate is higher. It's up at 22% for the latest number, although that's obviously preliminary. I guess my question is why are the numbers from Reagan Street and the Indiana State dashboard a little bit different? So, for example, the positive test rate is different if you back out what that rate is from the dashboard. So, for example, for the latest cases, it was like a little under 8% as far as I could tell. There were 954 positive cases, but over 12,000 tests, and also the number of tests, the number of positive test results, and the number of tests themselves. So, which ones would you trust more, or which seem more credible, and also why? Do you have any idea why the numbers are different? Thanks.
Yeah, good question. And I don't know completely why some of those numbers are different. Sometimes it's a matter of attribution. For example, a patient, we've had this kind of issue, a patient who may not be a resident of Montgomery County, or who lived outside of Montgomery County, but got admitted to a nursing home in Montgomery County. So their residence becomes Montgomery County, but then who is transported out to a hospital outside of Montgomery County and passes, they get counted once as a death, but whether it's attributed to the county that their originally resident was in, or whether it was because or attributed to Montgomery County because they were a resident of the nursing home. So there's been some attribution issues. The same kind of thing we see sometimes with reporting of the positive cases, where somebody may we may do the test in Montgomery County, but they may not be actually a county resident. So that creates sometimes a little issue. That usually is just a number, like when we're looking at the total number of cases that Regan Street shows for Montgomery County compared to the state, it's usually off by 3 or 4 patients, and we think that's an attribution issue. And also the Regan Street data lags a little bit behind the state data, because the state data gets updated first and then Regan Street. So, but the I don't think I can answer completely why those don't agree 100%.
Scott, I have a question. This is Byron Theta.
Uh-huh.
And first, before my question, I want to say thank you for being our speaker today, and thank you for being a good leader in the community about educating us about this virus. My question is about the virus load. I've heard a little bit about that, and I was wondering if maybe that's not what you were talking about early on in your talk about being in an elevator with a contaminated person or sitting at a table with one. Is the virus load more about how much of it you receive? I mean, can you be right beside somebody that's got the disease, but then you're back away from him right away? Is that?
Yeah.
Stand on that.
Yeah. There does seem it's really 2 factors. One is how much virus is the patient shedding, and then how long have you been exposed to it. So, for example, somebody who is asymptomatic and not running fever, who may have the infection, but the amount of virus they're shedding may be a lot less compared to somebody who is coughing and has high fever. So you might be able to be around that asymptomatic person longer before you might contract the infection. So the state, because there's no real good solid way to measure that, the CDC and the state then just give us a guideline, and the guideline is that if you are within 6 feet for 15 minutes or more to a positive case, then we view that as enough exposure to warrant putting you on a quarantine. Quarantine being what we do for folks who aren't sick, but they've been exposed and we're worried that they might become sick. And so some folks will be on quarantine and never get sick, which is great, but we don't want them, because that length of time it may take, they may get sick in 2 days, or it may be all the way out until day 13 before they actually get sick from that exposure. So that's why we put them on a quarantine. I'll also just throw this out. We are in the dark ages. We're doing what what we did 500 years ago in Europe during the plague, and the word quarantine was Italian. If you sailed into an Italian port during the plague, they made you stay on your ship for 40 days. And if your ship didn't have an outbreak of plague in 40 days, then they let you come ashore. So we're here in modern medicine doing the same thing that we did 500 years ago. And in terms of mask wearing, in medicine, we've been wearing masks for over 100 years to try to decrease the risk of transmissions of infection. And we're still doing that. We don't have a treatment for COVID except for remdesivir that we're using, and folks are sick enough to be in the ICU. That's an IV drug that you get 2 doses a day for 5 to 10 days, depending on how sick you are, or IV steroids. But short of being severely ill, we don't have a treatment for it. We don't have a vaccine. So our only tools are what you keep hearing from public health, and that is you have to stay 6 feet or more away from each other. And we want folks to wear a mask to decrease the transmission of the infection. And in this modern medicine, that's what we're left with. And I'll also throw this out. It's sort of human nature. We kind of view strangers as being more infectious than our own family, which is not true. If you're walking through Kroger and you pass somebody with an infection and you just pass by, you're not likely to catch it from them. But if you have your grandkids come over to the house and bring them into the building, you're far more likely to get sick from your family because you're going to spend more time with them, and they may not have been as careful as you have been in terms of maintaining distance and isolation. So when we do see little outbreaks, it's very often in a family group, and folks sort of just said, yeah, but they were my family. But if they're not living in your household, you have to view them as a risk. And so if you're having a family get together or a cookout or a celebration of some kind, try to do it outside. You're much safer outside. And you still should try to maintain that social distance so that if somebody in the group is sick, that you won't catch the infection. Right now, based on the current incidents in Montgomery County, if you have a gathering of 100 people, statistically, there's a 27% chance that one person in that group has the infection. And so if you ignore social distancing when you're in a group of 100, there's a chance you have a 27% chance likelihood of running into a person that's infected and running the risk of catching the infection. So groups are, the bigger the group, the greater the likelihood that somebody in the group has got the infection. And so just because the governor said we can meet in groups of up to 250 people does not mean that we can do that willy-nilly. We still have to be very vigilant about maintaining spacing in that group, whether it's a funeral or a wedding or a church service or a family reunion or whatever. You still have to maintain that social distance. Trying to stay away 6 feet is against human nature. It's very difficult to do. We keep forgetting, but you gotta keep trying at that. If we wanna try to keep this thing curtailed so that we can educate our kids, we've got to keep this infection from spreading through the community.
Scott, what's the view today as to what level of so-called herd immunity, what's it going to take before the virus kind of burns itself out and becomes less prevalent than it is today? Yeah,
in terms of herd immunity, I've heard a number of different numbers on that, and I'm not an expert in that, but the number that I think comes up most often is you need about 60% or more of the community to have immunity to the infection to significantly decrease the transmission. On our first round with the state in May, because they also tested antibodies on that round in May, they tested antibodies and the nasal swab to determine who had the infection at the moment, but also who had already had the infection. And that was sitting at 3.4% of Hoosiers either had antibodies to the infection or actually had the infection at that moment. So that was kind of disappointing because that was in May. We'd been running March and April with pretty high numbers. And, we were really hoping that that there were a lot more asymptomatic infections out there and a lot more people developing immunity, but it's not developing at that rate. And I don't think they're seeing, even in like Italy, that's now on the downside of this whole curve. Apparently, they're not even close to herd immunity yet. So that would be nice to get to herd immunity, but that also is going to mean lots and lots of people sick. And if we have 3% of folks end up in an ICU, if we have that many people sick end up in an ICU, then we'll be overwhelmed. So. So I think most public health experts aren't counting on herd immunity to help us through this until we get immunity based on vaccination.
Doctor, have you heard any issues so far with the schools that are open for football practice and that? Have they had any issues, or what are they doing to ensure that they're not passing it around?
They're not allowing the students to use the locker rooms, so kids have to go home to shower. They're trying to keep the kids outside. Being outdoors really is significant because it really decreases that aerosol transmission when you're outdoors. So that helps. They're trying to keep them in pods or groups that don't intermingle among the team, so that if one person gets sick, we only have to quarantine a smaller group of the team, not the whole team. That's part of the strategy. Wearing masks unless they're on the field, those kinds of things. We had one student on one team last week with a positive case, and we went ahead and quarantined the team because they had all been pretty close together and hadn't been practicing in pods. They'd been practicing as a group. So, and we quarantined them for 14 days because we really didn't want that to get out of control, especially when we're trying to keep things calmed down so that we can safely get kids into school. So we don't want athletics to torpedo our efforts at education.
Dr. Douglas, this is Elizabeth Justice. So in my house, we're getting 2 questions here. And again, I think we're all really grateful that you've done so much for the county on this public health issue. So really want to thank you. And my question relates to schools, and just a question of, is there a certain infection rate or a certain head count of people who are ill, at which time the schools would choose to close down, or however you would describe that scale?
Yeah, we've gotten some guidance actually just this week from the state health department in terms of how to approach that. If in a classroom we have one student who becomes positive, we're going to trace that student and quarantine the close contacts. So in the school system, and all the schools are planning on this, kids, they're going to have strict seating charts and trying to keep the kids cohorted into smaller groups so that if one child becomes positive, we'll determine who their close contacts were in terms of quarantine. So that's the initial plan with one student in a classroom. If there are 2 students that come up positive in the classroom, then the guidance is to quarantine the whole classroom. In terms of the school, the state said they are not giving a specific number in terms of whether to, what the threshold would be for closing a school, and a lot of it has to do with the rate of increase. For example, if we see a rapid increase over days, then in terms of numbers, and it looks like it's out of control, that would be different than if we had a steady number every day that wasn't increasing. So some of it is what the picture looks like in terms of how rapidly the outbreak is advancing. And the state wanted the local health department and schools to consult with them before closing. The earlier guidance laid out an option to, if there looked like there was an outbreak, to close for just 3 to 5 days, just really mostly for observation to see how many more kids were going to come up positive after an exposure. And if it looked okay, then you'd kind of open it back up. But right now the guidance is no particular number. They want us to consult with the state epidemiologist if it looks like things are ramping up.
Any additional questions from anyone out there? If not, we're at 1:07 already, so appreciate the presentation, Scott. It was very interesting, very sobering. We've got a long haul in front of us, I think, and as Elizabeth said, thanks for everything that you're doing for the community. Hopefully we can keep our numbers down, but I think, you know, your direction to be careful, be prudent, wear a mask,